Hello, everybody. Look, they're all out there in virtual land. Hi, how are you? Vesmachta, how are you doing? Okay, let's begin. Vesmachta in Yiddish is how are you? What's up? Kind of all that stuff. All right. Yeah, we don't have a whole lot left in this chapter to do, thankfully. And I mean, this is basically just looking at some of the things that are there. Oh, that was A. I see. That was a mistake. We don't need that. Okay, I'm getting there. Forgot something. Here we are. So sorry. I know. I should have been prepared before I interrupted your important conversations. Good Lord. Okay, here. Let's see if this will do it. I actually had the right one up. Okay. Oh, blood distribution. I apologize. I didn't know we had finished that particular PowerPoint, but I apologize. Here we are. I have it twice now. That's just wonderful. Sorry again. Okay. So we're looking at flow to specific areas. And this is where we left it off. So there's not a great deal to do. We're basically done once we get past this exchange stuff. Because the rest is lab, as far as I am concerned. I had sort of miscalculated. Let's go back to where we started with the brain. Constant, totally intolerant of ischemia, meaning if there's an absence of blood flow to the brain, it's going to immediately cause damage and potentially permanent damage. At the very least, it's going to have a significant impact because you're going to lose focus on what you're doing, maybe lose consciousness, faint, any one of a number of things that your brain always has to effectively be working at, relatively speaking, peak efficiency. Not that you have to constantly be on task and doing everything, but it effectively keeps you awake and alert when it's appropriate. So these are the big players that are there. So when there's increased acidity, increased carbon dioxide, basically it's going to assist with vasodilating, with allowing an increased amount of blood flow to compensate for effectively what this represents is a lack of oxygen, if you want to look at it that way. Because we only see increased amounts of acidity, which is decreased pH, and increased carbon dioxide at that point. But if they're exceptionally high levels, then everything is shot. I mean, at that point now, there's an overflow of carbon dioxide, and it's just, unless that's corrected, it can't compensate. Normally, we just start rapidly breathing and exhaling it. Okay? And there's lots of different things. This is sort of what we looked at before a little bit. So if it's decreased, they dilate. If it's increased, they constrict. Those are myogenic controls. Basically making sure that there's not, effectively think of the blood vessels being delicate. If there's in this way, you don't want to particularly constrict them with high, let's say this would represent high blood pressure because one could rupture, that would represent a stroke. But if there's not enough blood flow, they certainly have to dilate. It's the extremes again. So again, an important word down the road for you to remember, fainting, we call it syncope or syncopal episodes. Either one of those. When you see that SYNCOPE or some variation of that, you know it's fainting. And then anything excessively high like that, those numbers are scary. And again, I think I commented on that. You run into it in emergency room. We'll see these cases of rampant hypertension. We call it malignant hypertension. So they're just off the charts. And I mean, that's a monstrous accident to happen. Skin, okay, typically auto-regulated. Okay, it's not something, but really when it comes into play, it's mostly about temperature. Okay, so and again, this is something the autonomic nervous system will do some redirection. It's a way to, as well as perspiration, which is triggered by autonomics. This blood flow redistribution will allow heat to dissipate. Okay, and yeah, there again, it's like an additional reservoir. About, depending on the author you read, 5 to 10% of all of your circulation is sort of in the skin. And I don't know if you're going to do it. When you did blood vessels, did you talk about superficial and deep veins as yet? Did you finish with blood vessels? Yes? No?
We're moving on to respiratory.
You're moving on to respiratory. Yeah, okay. It's cool. Be happy you're not having me here doing that. Effectively, you have a whole network of veins. When you hear about some of these varicose veins, they're in veins that are under your skin. Okay? When you hear about someone with, one of the things we always worry about is someone getting basically called a pulmonary embolus. Pulmonary embolus is a blood clot that starts in a vein, breaks off, the vessels get larger, wider, go to the heart, go through the heart, where they get narrow again, pulmonary trunk into the heart, into the lung, can result in sudden death, and at the very least, highly significant problems. We get blood clots here in the superficial veins. They are not life-threatening. It's the deep veins. So the name that you'll look, the best names to talk to them are called DVTs, deep vein thrombosis or deep venous thrombosis. Okay. Superficial veins get clots too. They get thrombi as well. The difference is they can't, even if they break off and embolizes, which happens when a clot breaks off, they can't get to the lungs. They're going to meet a passageway where they can't get through on their way there. So the vessels actually get more constricted and more complex until they begin to get larger. So there are two kinds of circulation. So when you see somebody with varicosities, they are superficial veins for the most part. So even and what are they highlighted by? Other than being unsightly, typically they can get painful and unpleasant. Okay, it's by no means a life-threatening condition. Years and years ago, when I was not in particularly good health, I mean, I got a superficial vein phlebitis, for lack of a better term, and it's annoying. You get chronic swelling in the area. Had to wear like guys support hose for forever. Probably still should. Don't. Just lazy now. Deep vein thromboses are immediately life-threatening because that clot can break off at any time. Those are the ones you really worry about. That's why we use those squeezers, those intermittent compression devices when people have to be in bed in a hospital for a long period of time. And the problem is they're silent. That's the problem. We don't know that they're there. You may go in at bedside and see a patient, and it's what you should do when they know they've been in bed. You look at the extremities, check for edema, those kinds of things. And they're going to comment on that a little bit. So it really is something you cover in the anatomy lab, but it's not at this level of anatomy, it's not a focus point. At medical school levels, at graduate school levels of anatomy, it is a focus point, depending on the field that you're going into. So I've set that aside as a comment, so it's sort of as a thing like that. So blood through for the skin, body temperature, it can vary depending on your body temperature. So if you're generating it because of increased athletic activity, as much as generating it because you have a fever. Okay, so sometimes it's the sympathetic nervous system that's initiated by temperature receptors, and sometimes we're dealing with an infectious process. Any of those, but again, this is one reason. We know it sort of implicitly. I mean, moms forever are checking your temperature. Okay, the media, the little things because it's reflected in surface temperature. Oh, you look warm. Oh, you feel warm. That type of thing. By the way, you notice what I did. Never use the palm. Always use the back of your hand. You're going to use your hand. You're going to get your own temperature in there. There's all sorts of little tricks that you learn when you're examining people. And I'm sure they're going to share many of them with you. As an aside, I don't know. It's all the infectious disease worries we have. And I keep telling you about it, particularly if you have me for micro. I don't get excited about that stuff. It's good to put hands on people. And you know it's even better putting our hands on people when you don't have gloves on sometimes. I know we instinctively do that. You're worried about stuff, but that's why the good Lord made soap and water. Hands are a good thing. So it reassures people when you hold them and you touch them. In the meantime, you check their pulse. You can see if their skin is hot, dry, cold, clammy, waxy, irregular, bound down. Think of a million things you can check. In the meantime, you say, "Boy, how you doing today, Mr. or Mrs.?" Reassures them they know you're in touch with them, literally and figuratively in that scenario. But moreover, you're establishing a certain degree of bond, particularly if you're in the nurse. Doctors need that too, but a lot of doctors feel a certain need for detachment, for objectivity. That's why I probably failed in practice. I couldn't be objective. I like the people. You get emotionally involved with the people, and sometimes that impacts your decision making. There's a fine line between it that's there. Also, I can't manage money other than to spend it. Why else? So all of these things, as temperature rises, you figure it out. Signals, warm blood flushes in the capillary bed, heat radiates off, decreases, takes it away from that area. It's going to hold it in. Okay? And again, this is the idea of when we see that entrapment by the constriction, the blood that's still there hasn't had a chance to go back. That's why you get that reddish skin appearance when you're out in the cold for a long period of time. Hopefully we won't have to know about that again for a while. Just hope, not expecting it, but hoping. Look, we just had Ash Wednesday, right, a week ago. The ceremonial start of the golf season is Good Friday. Kids are coming up for a shower on 13th. So he's like, "Hey, Dad, you think I should pack my golf clubs?" I said, "Bring up your idea." April 13th. But by that time we'll be good to go. Lungs. This is the unusual part of it. It's the reverse. So the arteries and arterioles, wide, large lumens. We're not trying to restrict flow. Okay, much lower. Look at the numbers though. 120/80, 24/10. It's remarkable. You all dissected a heart. You know what the heart is like. How that left ventricle is so much more muscular than the right. This just gives you an idea of the pressures. The autoregulatory mechanisms are opposite. Low oxygen levels cause vasoconstriction. High levels promote vasodilation. This is one of the things that I continue to point out, and we'll address it again in respiratory. This is the first way your body is trying to help you, but it in many ways hurts you. So we call it a false sense of security. So take somebody with bad circulation, take somebody with lungs that are starting to fail because of environmental, or they've been a long-term smoker, or they have asthma and they're starting to develop emphysema. What happens there is your body does this intentionally. I have blood that needs to get oxygenated. It immediately, low levels cause vasoconstriction, high levels vasodilation. So if you have a lot of oxygen, it's going to direct the blood flow to those areas of your lung that have maximum oxygen. It's a safeguard. So it ensures if there's oxygen available, the blood in your lungs, blood coming from your heart that has to be reoxygenated, gets reoxygenated. And when we do respiratory, you're going to see an additional compensatory mechanism. So when we have to expel carbon dioxide, where do we direct the circulation to expel the carbon dioxide? To areas where those bronchioles, those tiny passageways, are able to be widened, and there's more of it. There's effectively easier to get rid of the carbon dioxide. Those two mechanisms alone, facilitating oxygenation and facilitating expelling the carbon dioxide, what respiration is. I'll tell you now, my lecture on respiration, it's the easiest system in the world to understand. You're going to look at it anatomically, functionally, in with the good air, out with the bad. Okay? Not hard. Very simple. And here, we're dealing with, we're directing the blood to where the good air is, where the oxygen is, and we're directing the exhaling to where there's openings that facilitate it being released. That's why all of a sudden somebody who's got a long-term problem, will walk into the doctor's office just as they had a bout of pneumonia. I'm so happy that's over. And they said, "Well, I have some bad news." "Well, the pneumonia's gone, isn't it?" He goes, "Yeah, but now you're going to be on oxygen for the rest of it." Because all of a sudden, you've reached that tipping point where you can no longer compensate. That's really the most intriguing thing to me sometimes about these body systems. We're good, and all of a sudden, why? Kidney's the same way when we get to it. Well, it's fine. All of a sudden, now you're telling me I have to be on dialysis? Yes. Because all of a sudden you reach the point where it just can't compensate. And it's some straw, camel's back, that deal. As my wife says, find me a cliche, Lou. Master of the cliche. So, blood through the heart, influenced by aortic pressures, ventricular pumping, we already know all that. Okay, when it's contracted, the myocardium blood flow ceases. So it has to rely on the stored oxygen. So think of it, when that heart pumps, those coronary arteries are compressed. So you have to have myoglobin in there to store it. During diastole, when it relaxes, the high aortic pressure forces blood back through the coronary circulation. You get the idea? So that, understand that circulation where it's intriguing. So when that muscle is the busiest, and the same thing with your skeletal muscles, when they're contracting, blood can't get in there, so it has to rely on the stored oxygen in the myoglobin. Okay, at rest, blood flow is 250 mils approximately per minute. Lots of different, but strenuous exercise. We saw that chart before, 3 to 4 times. Cardiac cells use 65% of the oxygen delivered. Other cells, you only use a quarter of it. So we have to increase the coronary blood flow. When we get to respiration, we're going to look at the curve. We're not going to get there for a while. You're going to have, this is where we sort of diverge because we still have to do the immune system. In anatomy, you're going to be looking at respiratory in more detail. By the time we get to look at respiratory, it's going to be a little while down the road. You're going to look what we call the oxygen utilization curve. And understand that when your venous blood only is missing about a quarter of the oxygen it came from on the arterial side. We have 3/4 of it in reserve. Very useful for whatever reason your blood stops flowing. At least there's some oxygen that can keep structures alive until we can restore appropriate flow from the heart. Okay. So we're going to get to that. The heart's not like that. The myocardium itself uses the vast majority of that oxygen. We just kind of keep that in the back of your mind down the road. Not a whole lot left. And all it means is blood flows, the smaller the vessels, the slower the flow. It increases again when it gets past the capillaries. So speed is inversely related to total cross-sectional area. The capillaries have an immense amount of area. There's more capillaries than you can imagine. And it's all about adding up total area. So the aorta may be huge, but there's only one of those. Capillaries, there are immense amount. Okay, so capillary flow allows for adequate time for exchange. That's the whole idea. It's there, and they're just showing it to you here. I mean, you can start the aorta, you may have a lot of velocity, but you don't have a lot of surface area to contend with. In the capillaries, you have minimal velocity, but you have a ton of surface area. That's what they're just trying to make sense of that. And if it doesn't make sense to you, it's not critical. I'm not going to ask you about it. Okay, and this is the whole idea that those sphincters we're talking about, being able to redirect blood flow to area. If you don't need the capillary bed, you don't need it for the time being. And this is the whole idea. Again, concentration gradient is the big player. Okay, some things are easy to move out and in because they can get through the membrane and get oxygen and carbon dioxide in the lungs or in the tissues. They are go right back to AP1. Okay, they're nonpolar, covalent, and they're small. They're tiny molecules, easy for them to get through the membranes. The water-soluble ones get through clefts. It depends on the capillaries. And you saw that initially when we started this chapter, some clefts are bigger than others, and we can adjust the size as necessary. In the kidney and some other areas, fenestrations, again, openings for a greater amount. They're really the filtration apparatus, if you want to think of it, for the kidney itself. And then we even will move larger things, though we don't do that a lot, but we have to use active transport for larger molecules. You don't see that a lot. You'll see that more when we start dealing with kidney, I think, than anywhere else. And they're just showing you something we saw before. The whole idea, I mean, here you're looking at, those would be fenestrations, for example. They're relatively small. You don't have to go through all that. So it goes out of the capillary at the arterial end. It comes back at the venial end. Okay? And And so all of these things, and these are the two forces. And this is the same two forces you're going to see when we start talking about kidney. So it's good to get a heads up on understanding them now. Again, hydrostatic means your blood pressure. It's the force. I mean, if you look at that vessel, okay, it's not just force going from the start of the vessel toward the end of the vessel. It's forced in all sides. The force is being equilaterally. It's pushing against. It's not only causing blood to flow through, it's pushing against the walls of the capillary. That's the idea. That's why it filters out. All those walls are under identical pressure. What's holding it in, we call that hydrostatic force of water pressure, blood pressure. The colloid osmotic pressure is, again, it's those proteins. Those proteins that can't escape because they're too big under ordinary circumstances. What they do is they exert a force. We learned about it when we talked about blood. What does albumin do? Basically exerts what's called colloid osmotic pressure. It's holding it's what proteins do. They hold water to them. Very useful. So the hydrostatic pressure, okay, at the capillary end, you can see the difference. When we get to the kidney, you're going to see a bigger difference. That arterial end is going to be 55, not 35. But it's a different system. This system, 55, would damage those capillaries. They're a little bit more delicate here. So 35 at the arterial end, 17 at the venous end, and we do the math. Okay, and basically it's easier to look. So the osmotic pressure is about 26. That's holding it back in, and these other two are not that critical. We're not going to go through all of that. We're not going to go through all of that. We're not going to go through all of that. This is useful. Okay, so there's a lot of illustrations you don't need. When I do it with my physiology class, we go through the advanced physiology. This is the force pushing it out. That's your blood pressure. This is the force pulling it back in. That's the colloid osmotic pressure in that capillary at the start of it. There are some other forces that are there based on where it's going, where it's coming from, and where it's going to. Effectively, they're minimal, if you want to figure it that way. Do they add a little bit more about pushing it out? There's some proteins in the interstitial fluid. They're exerting a little more tug. Not a big deal. The whole idea is the net effect. The net filtration pressure is substantial enough. In this case, it's 10 millimeters of mercury to push fluids out. The oxygen and carbon dioxide, we don't have to worry about that. With them, it's all about which there's more of. In the bloodstream, there's more oxygen. In the tissues, there's less. There's more carbon dioxide in the tissues. In the bloodstream, there is less. So the partial pressures of those gases induce them. Well, partial pressure is the same as concentration. So gases move that way. You need to remember that when we get into respiratory. The same thing happens in the lung. You have an abundance of oxygen every time you inhale, and you get rid of an abundance of carbon dioxide. That blood that's coming from the right side of your heart, the pulmonary circuit, has about a quarter of normal depletion of oxygen and an abundance of carbon dioxide. And so all it is. It's just reversing what's going on in the tissues. So we look at this being, we call this cellular respiration. Then you're going to see in the lungs, we talk about pulmonary respiration. They kind of reverse each other vis-a-vis oxygen and carbon. So try to glean the big points. I'm not asking you to go into the smaller points that are there. Now on the other side, on the flip side, okay, now after that fluid has basically gone out, it's reduced to 17. But those proteins were in there. They didn't change. The proteins were 26 before. They're 26 after. Okay. So what they're going to do is they're going to pull those fluids back in. All right, there's still some proteins out there, but they don't offset it by much. So in this part, your outgoing pressure before was 10. Now your incoming pressure is 8. That's still significantly different enough. It is significant enough would be a better way to express it. To pull back the fluids and whatever in them, waste products. And again, we don't worry about oxygen and carbon dioxide. They'll take care of it. They'll go where they have to go as we get there. And so whenever we have an excess, either we don't have a sufficient amount of proteins to exert colloid osmotic pressure, or we have overwhelming blood pressure to push fluid out, or the whole circulatory system ain't working. And this is what happens when the heart starts to fail as a result of high blood pressure, perhaps more than anything else. As that right heart failure, remember, it's a plumbing system. Ultimately, if we can't push it into the lungs, it backs up. We're not going to back up, though. You could see it going up here sometimes. It's good old gravity. First place you're going to fill with the abdomen. The first place you really see it is in the lower extremities. We call it peripheral edema. So, and there's a variety of things. Valves could be bad. There could be a blockage. I mean, valves being bad, you might see, you certainly happen. It could be a sign that there has been a deep vein thrombosis. It could be just a localized blockage, possibly. More likely this, congestive heart failure, high blood volume, because it manifests itself not just by the heart, but it impacts the kidneys, it impacts other systems as well. And so effectively what happens, an inflammatory response, we wouldn't be surprised to see this there. There's all sorts of things, but more or less, if the heart's bad or the kidney's bad and you have, or for some reason you're not making enough proteins in the liver, read that as malnutrition, okay, or some type of primary liver disease, or as you can see, any type of kidney disease, something systemic is about, you're going to end up with edema. The fluid it's not going to be held in. If the proteins aren't there, it's going to come out, right? If the kidneys can't get rid of excess materials and there's an overabundance of fluid, it's going to come out. If the heart can't pump it around fast enough, it's going to come out. The difference is diagnostically, and you certainly don't have to know that. When they asked me, when I was auditioning, interviewing for a particular residency program, they asked this question because I was not for circulation. It was like, hey, one of those gotchas. You were going to ask something like that. The question is it on both sides or one? If edema is on one side, look for a reason for an obstruction. Is there? Women ordinarily, when they're pregnant, the baby typically lies more often on the left than on the right. So it's not unusual to see a degree of edema or fluid accumulation on one side or the other. Left more common than right, but that's not a hard, steady rule. It could be a tumor block. There's a lot of reasons. It could be a blood clot. When you see something unilaterally, look for something that's going to cause that obstruction mechanically, or is there some other adverse thing that's going on? Blood clot, tumor, something pressing on it. So it directly or indirectly creates the obstruction. If it's bilateral and symmetrical, that's a great term. It means on both sides looks the same. Like your body's bilateral and symmetrical. Your hands look alike. I know there's right and left, but bilateral and symmetrical. By and large, everything's there. That's the beauty. We always look for asymmetry. But when something is occurring on both sides, it has to be a centralized force. There's only two things that can create fluid overloads in such a way, either from an absence of proteins or it's typical. I mean, liver disease would be in there too, to make it three. Heart, liver disease, kidney. And by and large, they're going to be evident. So you immediately would say, oh, we better make sure their heart's okay, their kidney's okay. And I mean, if you're dealing with somebody, well, it's the old, do you drink? Well, only on occasion. What does that mean? Oh, I have a beer or two every night, 6-pack. It's like me as a smoker. Ooh, did you remember the time they asked me that? Yeah, I have, maybe half a pack a day. That's a minimum. Remember that whole idea patients lie? When it comes to alcohol and smoking, whatever they admit to, double it and then add some. Stein's rule. It's like when someone's doing we had a new deck put on. Stein's rule. Well, my wife said, what do you think it'll cost? I give her an estimate. I said, now we just have to double it and add some. Because I have no idea. Great deck. So all of those types of things. So edema can be caused by a lot of things. Excess fluid, and it generally causes pitting. Pitting means it's mostly fluid, water. So, and it can do all the things. I mean, it's an impairment for anything else to get through. And when if you have edema, then gases can't get through. You can't exchange oxygen, carbon dioxide, nutrients, and waste products, etc. We can compensate for it, but eventually there's a price to pay. This is what it looks like. So, I mean, they're demonstrating over the dorsum of that particular foot. But what happens is you make sure it's over a bony prominence. So what you do is you find, if it's lower extremity, pick a malleolus. I personally pick medial because it's easier, especially if it's bigger. Put your finger over that and press, take it away, and that's what pitting looks like. I mean, sometimes it's so bad, you can walk out of the room, make notes on a chart, talk to somebody, even see another patient. You come back, it's still pitting. So we grade it from 0, it's not there, to +4, typically. They will explain to you from a nursing or whatever clinical domain that you're going to be in what that means, 0 to +4. So either you got it or you don't got it. Okay, so, and that's just increasing degrees of severity. What happens over time, the solids in there, the proteins and things like that, begin to become sort of permanently fixed, and you get non-pitting edema. And so there's different kinds. In this, we're talking about pitting, being fluid overloads. The longer it's there, the less likely it is to get rid of. So, well, it's not pitting edema. It doesn't mean it's magically cured. It means it's been there for so long, it's permanently altered, and you're going to have a difficult time getting rid of it. And we'll look in the next chapter we do about the lymphatic system. There's something called lymphedema, and that's and I mean, a classic cause of that would be post-operatively. Typically, if you did not know, and I would suspect you, if you don't, you will certainly find out soon, from just because of the work you're doing and the people you know. When we have, particularly for breast cancer, particularly if they have to do mastectomies, total or partial, they always have to do a lymph node dissection. Okay, under the axilla, because that's where it spreads to. The tail of the mammary gland kind of goes in that way. So where's cancer going to spread, it's going to here. So you always got to do a lymph node dissection. And what happens is, down the arm. And it's really bad. I mean, to the point where you have to put a sleeve on and push it out. And the minute you take the sleeve off, it comes right back in. I mean, it's very good. The wonderful actress, Kathy Bates, she actually did it because she had a double mastectomy. She actually showed what she went through every day. So, and she's lost a ton of weight, but what she's gone through every day, so her arms didn't look bizarre. But I mean, she's very happy because she's around to talk about it. If you want to see very strange movies called Misery, she won the Academy Award when nobody knew about her in 1990. And it's another one of those wonderful Stephen King novels. So you can imagine. Not ringing a bell? You didn't see it? Oh. You want to see that? She's not evil as much as she's possessive. Not possessed in that kind of sense. Possessive of the late Jimmy Kahn. Just say, this is all lab. We're basically done with that. Lab. See, venous pathways, a little bit different, okay? And so they don't show you the superficial veins. I'm not going to bother you with it because it'll upset you. And I mean, I never get anything out of that. I hate that. I hate these pipe diagrams. If I look at that first thing, too busy. There's too much stuff there. I can't look at that and retain it. I can look at that and retain it. And I'm giving you some tips where we have to. Did we doing that? Did we do that yesterday? Was there a test? The whole trace the blood test? What? Oh, how hard could that be? It's easy. Wasn't bad? Oh, God bless. I feel so much better. And you guys, some of you have it this afternoon. Right? Some people have it, right? 3 to 6. No? You don't even know if you're having a test?
I'm not in that one. I took it yesterday.
Oh, never mind. I would have been a little upset if you hadn't studied for it. I was studying for your test. So I'm not going to go all these. I love this stuff. You don't have it. You don't have to worry about that. You don't have me to kick around for this. I love that. There's the vein, same thing. This is what I mean. These are the ones here and here are called superficial veins. They're the ones you use to draw blood. Why you can't start an IV in a deep vein because inevitably you're going to damage it and lead to a clot. Sometimes you have to catheterize a deep vein. That's different because you're putting in an indwelling catheter. But you never, I mean, that's what they're there for. They're because if they're damaged, it doesn't matter. Didn't I tell you my arms were totally black from all the venipunctures I had? Both arms when I was quite sick. I didn't tell you that. I was in a hospital for my hemoglobin was 5. I just had a 3-unit transfusion to try to get it high enough so they could do a procedure to go in and stop the bleeding in the ulcer. I was in the hospital for 9 days, went home for like 2 days to build up some more strength and went back in and was in for another 10 days. I can remember acutely like it was yesterday. I reminded my daughter about this because she was 14 at that time. It would have been June of 2000 when that happened. So we're pushing 25 years, and she threw herself on me on the bed and said, "You're not going to be there for my wedding." I recited that when the little, the little speech that the father of the bride sometimes gives at the wedding. See, I told you so. Don't worry, I'll be there. The fact that you had to wait till you're 39 years old to do that, that's on you. Yes, ma'am.
So, whenever you do, like, say you did an IV, what makes your veins rupture?
What makes your veins rupture when you
Like,
do?
don't they, like,
When you start an IV?
yeah.
They should not. Okay, so when things go wrong, and some people the veins are bad. It's very hard to do. People have abused their veins, like drug addicts and things. That's hard. Okay, and I hate it when somebody. Well, do you have veins that roll? Because to me, that's somebody's already trying to justify when they miss. I don't like that. When somebody goes like that, how are your veins? I said, do you know what you're doing? I don't go for that because that's somebody who's not confident in their work. Uh, Typically, it's about technique. And you'll hear anybody who operates or does invasive things, the 3 things that make them work out great, or 3 things that make things bad: technique, technique, and technique. It's like real estate: location, location, location. You just learn to do it right, and that's what nursing is great at that because they're all about the technique. This is the way to do it. We'll continue to do this. All those little steps until they become second nature to you. Put this here, put that here, put this here. So all those things you can focus on finding the vein, making sure the vein is adequate, making sure when you stab it into the vein, you don't push it too far or not far enough. When you have to look for when you get the venous return, you want to make sure it's centered, and patients can help you. Because if it hurts, it's not good. I mean, it's going to hurt when you stick them, but and you can't. You just got to get to the point where that's not going to bother you to do that. As my friend who's deceased, who I went to school with, who was a medic in Vietnam, Navy medic. He says before we all were like that to start. He says you got to bloody up a few until you figure it out. And it's true. It's not nice, but it's true. That's why when we learned to give injections and do IVs, we did them on each other. Pick someone who's a good friend and do that. And we were the partners for each other. But effectively, there's a way. I don't know how they're going to do it there, so I wouldn't want to presuppose. We would use typically. I always felt the best way was to come in at a 90-degree angle and then angle it to 45 and come in to avoid penetrating. I do not know what the current way of doing it is, so don't listen to me about that stuff. That's just the way it was, and I learned that way too by starting it. It's how you avoid problems. It's easy to go through a blood. It's not the end of the world. Okay, I live by the 2-stick rule. I'll give somebody 2 shots. If somebody comes to start an IV with me, and I'm in for a procedure or something like that, they don't get it by I got to try that again. And basically, after the second one, I go, nope, get something else. You kind of look at me, no, 2-stick rule. Maybe it's not. Sometimes it's not your day. People don't understand that. A lot of times it's not your job. We all do that. It's unique. I don't know if that helps to answer your question, but you'll be good with it. I didn't have a gifted pair of hands. I was useful. I could do basic nuts and bolts surgery. I was very good plastic. So when you make it look pretty on the outside, people think it's great on the inside. It's true, surgically, but I didn't. I was not gifted. There are people who are just boggles the mind. They have. It doesn't necessarily mean they're bright. I had occasion to say the same thing I say to every class. The smartest guy in the class isn't always the most successful doctor. I had the highest scores, board scores in the country when I graduated. I made the least money, I'm sure. So it doesn't always equate, but it's the same thing with being a lot of the people who were very good surgeons. I see them giving talks, and it's like, and I'm amazed. I'm watching videos of their technique. Gorgeous. I couldn't do that. But they got the hands for it. Okay. All right, enough of me. I don't think there's anything else here of any consequence. It's up to you. But those are the veins you're looking for. This one, you hold your hands like this. Cephalic toward the head, basilic. So on the radial side is the cephalic vein. Here is the basilic vein. So if you do them this way, and they're the ones that are going up, they're interconnected. The whole network of blood vessels comes in this way. And then what happens, you just occlude it a little bit. It doesn't matter. You could do it yourself. Tourniquet does help. Pump a little bit, and it just fills them up because you're occluding it. And then now you got a vein. Got a real good vein over here. A lot of people like that. And you want something, depending on the procedure, how long it's going to be in there. So, just doing a venipuncture, you use what's called the median cubital vein. That's the connection between the cephalic and the basilic going across. There's a branch that's right in the cubital fossa, the elbow indentation. Good thing, they're always neat places. Axilla, cubital fossa, popliteal fossa. Anatomically speaking, there's a lot of business going on, traffic. And you just get right in there, boom, it's heavy dance. But they had to stick me so many times, my arms turned black. Everything started to bleed. It wasn't bad technique. When you're sticking you 3-4 times a day. I had a triple ported. So, and you have to use like a central baseline, like the IJ intrajugular line or subclavian line. I had 2 for inflow and 1 for outflow. So they didn't have to stick me anymore. They could just pull it out directly. I had 1 for feeding, for TPN, total parenteral nutrition, because I couldn't eat anything. And then I had 1 just for fluids and whatever medicine. It's a clinical term for what I was. Mess. So if you ever do get to meet my daughter, just remind her about her throwing herself on the bed. To me when she's 14 years old at the hospital. Go figure. Goodbye. I'll see everybody here. We know when, we know why. Hopefully we'll get, if you need some extra time, the next class is not quite as full, so there's room. In other words, there's option, but we probably can't get in here until just about when it starts. Like usually, she takes till about 5 of, that type of deal. Yes.
Can I come to your office after 11? Or